Greetings, friends. Today's lecture will be about cleft lip and cleft palate, epidemiology, causes, and pathogenesis, the most common syndromes. Lecture, Department of Pediatric Dentistry, Associate Professor Bezrukov Grigory Sergeyevich. Phase is cleft lip through microscience. The following: asymmetry of the red border of the upper lip, asymmetry of the wing of the nose, atypical shape and position of the lateral incisors and caniness of the upper jaw. Prognathia. Cleft palate, others, microscience. Shortening and deformation of the soft palate, splitting of the uvula, soft palate, diastema, atypical shape and position of the lateral incisors and caniness of the upper jaw in combination with the groove of the alveolar process. True progenia. What is the epidemiology in these countries? For example, in Russia, in Africa, in Japan. Why are these countries chosen? After the birth of a child with maxillofacial pathology, a comprehensive examination by specialists is necessary for identifying deviation somatic nature and concomitant malformations and carrying out the necessary correction aviations in the preoperative period. The hypothesis of genetic heterogeneity. About 38% of cases are classified as familial, 62% as sporadic. The role of heredity in the development of an anomaly. The most common occurrence and is recessively associated with the chromosome X, but can also be caused by autosomal dominant inheritance. Organogenesis and morphogenesis of the jaw. The fetus may violate it under the influence of hereditary effects on the embryo of diseases transferred by parents, as well as due to physiological and anatomical disorders of the mother's genital organs and the incorrect position of the fetus. International classification of diseases. 1. Cleft lip that can be bilateral, median, and unilateral. 2. Cleft palate. 1. The cleft of the hard palate is bilateral. 2. The cleft of the hard palate is one-sided. 3. The cleft of the soft palate is bilateral. 4. The cleft of the soft palate is one-sided. 5. The cleft of the hard palate with the cleft of the soft palate is bilateral. 6. The cleft of the hard palate with the cleft of the soft palate is one-sided. 7. Cleft palate is median. 8. Cleft tongue. 9. Cleft palate is atypical bilateral. And 10. The cleft palate is atypical unilateral. 3. Cleft palate with cleft lip. 1. Cleft palate with cleft lip bilateral. 2. Cleft palate with cleft lip unilateral. 3. Cleft palate with the cleft lip bilateral. 4. Cleft palate with cleft lip unilateral. 5. Cleft or hard and soft palate with cleft lip bilateral. 6. Cleft of or hard and soft palate with cleft lip unilateral. 7. Atypical cleft palate with cleft lip bilateral. 8. a typical cleft palate with cleft lip unilateral. Cleft lip can be complete, incomplete, hidden, as well as cleft palate. Classification. Etiologic principles. 1. Clefts of the primary and secondary palate. Unilateral cleft palate, bilateral cleft palate. 2. Clefts of the secondary palate. Cleft palate, clefts of the soft and partially hard palate, median cleft palate. Submucosal or hidden fissures are not distinguished into any independent unit, since such a form can be observed with any type of fissure. Borders of palate sections with congenital cleft according to the clinical and embryopathogenic principle. 1. Anterior and anterolateral section of the palate corresponds to the primary palate in embryolaterogenesis and the fusion zone of the primary and secondary palate. Locus minoris resiste for the information of flaws in the palate. 2. Middle section of the palate corresponds to the secondary palate in embryolaterogenesis and the confluence of the palatine process. 3. Zone of the border of the hard and soft palate, the area of viscous attachment of the muscles of the soft palate and the greatest tissue tension during uranoplasty. 4. Soft palate. Spatiotemporal expression of growth factors in pathogenesis differs from that in a hard palate. Tissue differentiation is of a different type. Borders of palate departments with congenital cleft on localization. 1. Anterior palate. 2. Middle palate. 3. On the border of the hard and soft palate. 4. Soft palate. 5. Total flow of the palate. Borders of the palate sections with a congenital cleft in a room. 1. Spot. 2. Split. 3. Oval or round. 4. Irregular shape. Some accompanying non-fusion of the upper lip and palate syndromes of the maxillofacial region. About 300 syndromes have been described. The correctness of the diagnosis depends on the examination of the patient. Complaints of the patient, his relatives, or person who accompanied the child. Medical history, like anamnesis morbi, anamnesis of life, like vitae, objective examinations of organs and systems, objective examination of the maxillofacial region, preliminary diagnosis, that can be called suspicious diagnosis from the word suspicious. Data from additional examination methods, results of a general blood test, biochemical, immunological blood tests, urine, radiography, compute tomography, magnetic nuclear resonance, osteometry, scialography, ultrasound, thermography, angiography, cytological, pathohistological examination, etc. Differential diagnosis and final diagnosis. Pierre-Robin syndrome. The type of inheritance of this syndrome is unknown. Congenital hyperplasia of the lower jaw, micrognathia, non-union of the palate. Language anomalies like glossoptosis and macroglossia. Van der Waals syndrome is inherited in an autosomal dominant manner. Congenital symmetrical fistulas of the mucous glands of the lower lip combined with the non-union of upper lip. Treacher-Collins syndrome. The type of this inheritance is unknown. Congenital syndrome with a typical set of symptoms: deformity or hyperplasia of the zygomatic process of the frontal and temporal bones, underdevelopment of most and zygomatic arch. The lower orbital edges are displaced downward, the orbits are deformed, there may be no external auditory canal, deformation of the pterygoid process of the phrenoid bone, upper and lower jaws, partial non-union of the palate, fistulas on the lower lip, asymmetry and deformation of the skull are often observed. The chin may be underdeveloped, the nose deformed. Franz-Jehty syndrome. The type of his inheritance is autosomal dominant, a complex of maxillofacial deformities accompanied by a large half-open mouth. Here you can see like an example of such syndrome. Palato-digital syndrome. Quite common in the practice of dental surgeon. It is manifested by deafness, non-union of the palate, dystrophies of the face and skull, like frontal tubercles and superciliary arches protrude, a wide nose with the retraction of the bridge of the nose, micrognathia, etc. They are quite common. Orofacially digital syndrome can be in two variants. Ectrodactylia, ectodermal dysplasia, and Cleft syndrome. Unilateral or bilateral non-union of the lip and palate spars and thin hair, dry skin, microdentia, changes in the normal shape of temporary and permanent teeth, enamel hyperplasia, stenosis of the lacrimal canals. Hyperplasia of the maxilla and multiple pigmented nevi are also observed. Hemifacial microsomia. Syndrome 1-2 gill arches. The pattern of his inheritance appears to be autosomal dominant. This is a group of defects resulting from violations of the formation of gill slit, 1 and 2 gill arches. Apert syndrome refers to complex syndromes of the maxillofacial region and skeleton. Clinical signs are hypertelorism, wide bridge of the nose, flat eye sockets, bulging eyes, non-union of the palate, poor vision. There are changes in the skeleton, short stature, pilodactylia. This syndrome is accompanied by mental retardation. Klippel-Feil syndrome. In the oral cavity, the syndrome is manifested by malocclusion, non-union of the hard and soft palate, deformities of the teeth, and jaw cysts. The appearance of the patient has a typical sign. A short neck, you can imagine like the head sits on the shoulders. Head movements are limited. This is because first vertebra merges with other vertebrae or synostoses with a occipital bone. There are anomalies of the ribs, congenital heart defects, high location of the shoulder blades. Development of the facial part of the embryo ends mostly by 10-12 weeks prenatal development. Therefore, the development of pathological changes is possible only in this period. This is important. A pediatric dentist needs knowledge about the nomenclature of diseases to be recorded by the dentist, the timing of surgical interventions, the structure of a specialized service where the patient can be provided with specialized assistance. The role is to identify the disease, the most striking symptoms of which are determined in the MPA. A task is to show the staff of the maternity hospital and the mother how to feed the baby. Abnormally, a child born with a cleft begins feeding through a tube. The task of orthodontic treatment. Normalization of the mutual position of individual teeth and dental arches of the upper and lower jaws. Speech disorder, one of the most severe functional manifestations of congenital cleft lip or palate. Here you can see the scheme of medical and preventive care for children with cleft upper lip and palate. Fill-in-form cleft. Important. Information for primary examination of children with cleft face and jaws for maternity hospitals. Information card for parents. Stages of treatment and observation by dentist specialists. Map of planned surgical treatment and observation of the maxillofacial surgeon and dental surgeon. Map of preoperative preparation of children with cleft face and jaws. Card of postoperative treatment. System for assessing the condition of the upper lip after haloplasty. The system for assessing the state of the thigh after uranostrophoplasty. Personal card of the quality of surgical treatment of a patient with cleft lip. Map of complex dispensary observation. Card of dispensary observation at the orthodontist of children with cleft face and jaws. Card of dispensary observation at a pediatric dentist for children with cleft face and jaws. List of children with cleft face and jaws. Card file cards approved by Ministry of Health of Crimea. Photo library. Informing in the approved form of regional specialists and interregional centers. Information for initial examination of children with facial and jaw clefts. For maternity hospitals. Psychological rehabilitation of the mother. Feeding in a semi-horizontal position of a child. When feeding, the breast should obturate the oral fissure. For artificials, a steamed rubber nipple is used with a moderately wide hole at the end. The nipple fits into the defect of the upper lip and palate in such a way that it separates the oral cavity and nose and ensures tightness during feeding. Neonatologist or pediatrician consultation. Identification of general somatic pathology. If necessary, referral for dental treatment. Informing the mother about the need to contact the dentist at the place of residence. Orthodontist consultation. Consultation with an oral and maxillofacial surgeon or dental surgeon. Explanation of the principles of dispensary observation. Upper lip condition assessment system after haloplastia. Full name, age, name of the operation, date of an operation, date of inspection, qualitative indicator, the appearance of the upper lip, harmony with the parts of the face. Excellent 3, good 2, and satisfactory 1. Upper lip function. Symmetrical in full 3. The movement of the lip fragments are not coordinated, limited. That's 2. The movement of the upper lip is accompanied by skin retraction. That would be 1. Symmetry of the lateral fragments of the upper lip from the columns to the corner of the mouth. Symmetrical 2. Not symmetrical 1. The state of the Cupid's bow, symmetrical 2, and no, that would be 1. Column length, the same, 2, different 1. The severity of the red border, pronounced 3, moderately pronounced 2, narrow 1. Scar quality, little noticeable 3, hypertrophied 2, and skin deformation counts as 1. Position base of nose and nostrils. The nostrils have the same diameter and symmetrically arranged wing. 3. The nostril is narrowed, the wing is symmetrical. 2. The nostril is narrowed, the wing is not symmetrical. 1. Quality indicator in points. Excellent from 24 to 22, good from 21 to 18, satisfactory from 17 to 13, and unsatisfactory from 12 to 9. A system for assessing the condition of palate after uranostaphyloplastia. Full name, age, name of the operation, date of the operation, date of inspection, qualitative indicator, etc. The length of the soft palate normal, shortening of the soft palate 2, soft palate tissue defect 1. Tongue shape and symmetry, correct shape and length 3, shortening of the tongue and asymmetry 2, absence of a tongue 1. Condition of the palate, mucosa. Smooth surface 3, minor scars 2, rough deforming scars 1. Integrity of the palate tissues. Saved 3, point defect 2, defects of the alveolar process and large defects 1. The state of the middle pharynx, norm 3, minor expansion 2, moderate expansion 1. Soft palate function. Fully saved 3, moderately pronounced 2, weakly pronounced 1. Here you can see the following points of the quality of operation that indicates the result. Here you can see the picture of different approaches to treatment. You can see the process of the operation. Thank you for your attention. If you have any questions, please contact us.